Welcome to Medicine. I'm Dr. Othniel Doolittle, here today to talk more about leadership. I'm here with Dr. Riley, who does both hospitalist medicine and ER. We wanted to talk a little bit more about how you switch back and forth between those two, and then also explore being a physician leader, what is required to make that happen, and how you can be an effective physician leader in the hospital you serve. So welcome, Dr. Riley.
Thank you.
Thanks so much for coming in today.
Sure.
How long have you been practicing medicine now?
So I finished residency in 2006, and that's when I relocated back to this area.
And you did family medicine?
Correct. Yeah, I did full scope family medicine at that time. I was doing inpatient, outpatient, upper and lower endoscopies, delivering babies.
Wow.
A little bit of everything.
Yeah. What was the thought process as you went into residency? Like knew you wanted to go into family medicine?
Yeah, so I really enjoyed a little bit of everything. And my initial thought process was to do family medicine, and I had actually entertained the idea of doing an adolescent fellowship. Once I got into residency, two things happened. I had a family with three wonderful boys at that time, and I really enjoyed family medicine and all of the procedures that were involved. I loved OB, I loved delivering babies. I did the operative OB track at our residency program, and the idea of moving and leaving Southern Illinois to do a fellowship, and then moving again into an academic program, and then moving again with our three children didn't make sense.
Yeah.
Tara and I really wanted to try to have the boys in a school system where they would be supported and not having to make those leaps several times throughout their academic careers.
Makes sense.
Yeah, so what I chose to do was to do full scope family medicine, and really enjoyed it.
So as young physicians, whether you're in med school or beginning residency, are you always telling them, you have a lot of students shadow you?
We do.
You're a great teacher.
We do. We do. I love education. The rotations are now, I pretty much have a student with me every day. We work with the Lincoln Scholars Program based out of SIU in Carbondale. And so every day that I'm in the hospital, most every day, we have a student that's with us. And having the students with us really pushed me to keep learning. It's one thing that whenever they're there, they ask great questions and we have great discussions.
So even though you didn't go into academic medicine found you.
Absolutely.
Yeah. So are you telling all of them, put family first in your career decisions, or was that something that you think is more unique to you?
I think everybody has to choose their own path. I can tell you there were certainly times in my life that I didn't always put my family first. My family probably struggled because of that, and that's certainly hard. In the position where I was, while I really enjoyed it, it was a lot of time. I really enjoyed the prenatal care, but there were times when, I would be called away at a moment's notice, or our sons would be, in the middle of a baseball game, and I would be behind the dugout trying to answer phone calls regarding abnormal labs or CTs or something. Because you're really, as a small town family physician, you're on 24/7. Yeah. And so that would be stressful for our family.
Yeah. So what position was that exactly?
That was when I was still working and doing that full scope family medicine.
And then now, what is your primary work scope?
Yeah, so in 2014, I switched over to working as a hospitalist. Our boys were about middle school age then, really starting to get into activities. working as a hospitalist. I work a traditional 7 on, 7 off schedule, and our boys really got accustomed to that. Knowing when my week on and my week off was going to be.
Yeah.
And that week off, I was really able to spend time with them, spend time with the family. We've maintained that schedule, and that's what I continue to do now. I currently, my full-time position with Integritas is at Deaconess Illinois Crossroads in Mount Vernon. And I will tell you, my hobby whenever I'm not working as a hospitalist is to pick up the ER shifts.
Yeah. When did you start picking up ER shifts first?
Yeah, I think it was 2015. So my first year that I was doing just pure hospitalist work, the ER director, the hospital where I was just like, why don't you come and work in the ER? And it's like, no, I don't think so. I think I'm okay. Of course, during residency, we do lots of shifts in the ER.
Yeah.
Med school, we worked a lot in the ER. Residency, we did, but I hadn't really done it since then. They needed help in the ER, needed some shifts picked up. Okay, I agreed to do it. Once I started doing it, I really liked it because, as we know, in hospital medicine, we deal with a lot of problems that are different from what you see in the ER. In the hospital, you might be dealing with those exacerbations of chronic problems, whereas in the ER, you've got sometimes more acute things going on.
Yeah.
And it's just a different set of skills and a different variety of patients to see.
Yeah.
I think because of my background in prenatal care and doing women's health, I'm one of the people that's not scared when a pregnant patient comes in. Like, I enjoy those visits.
Yeah. When you walked in, were there procedures that you felt like you weren't ready for, or family medicine, full procedures? You were doing endoscopies and
So
deliveries.
I had been doing upper and lower endoscopies. So if I rewind back to residency, the residency program that I did was through St. Louis University and was a combined program with the Air Force. And that program trains their residents from the Air Force side to be able to go anywhere, and you might be the only physician there.
Yeah.
And so that's the way that they wanted to approach it. And so I knew that was perfect for me. I knew that I wasn't going to be in the Air Force, the military, or being deployed to Afghanistan or anywhere else.
Right.
But I knew that wherever I went after residency was likely going to be a small town. So I just soaked up everything that they had. So one thing that we did were we continued to do all the procedures. So we put in central lines whenever we were there. We would spend time in the ER and put in the chest tubes with the ER docs. As far as prenatal care on labor and delivery, there were 4 of us that did the operative OB track. So doing the surgical type procedures was we were comfortable with. As far as ER procedures, one thing that came on the scene that was new to me was video assisted laryngoscopy, and that just wasn't a thing in the past. We all did direct laryngoscopy, and so
That was a game changer for sure.
It was, and so for me, like, all of a sudden, this new technology came in, and basically it was like, here, use this, it's better.
So GlideScope started to come in.
The way I perceived it was one day this GlideScope appeared. No information was really passed on or anything. This thing just showed up in the room, and it was given to us like, well, here, try this. Well, it's a different technology. It's different skills to use, and and to me it was difficult,
Oh yeah.
because while you're trying to accomplish the same task, it's a slightly different procedure, and that was challenging. And so I worked on that. I went and did a specific course focused just on that, and I can tell you now, I really like using it. I like working with the students. I can tell you, we've had a couple this opportunities this week where we got the chance to use the GlideScope technology, and guide one of our students through it, and so it's really good. Yeah.
When they dropped it off, it's just so funny because like this happens all the time in healthcare, where like there's all this discussion of like the Swiss cheese model and we need to have good processes, and then this stuff actually just happens all the time where they're like, hey, by the way, here's the new ultrasound machine, don't break it, but nobody knows how to use it. Nobody knows the password for it. And when the GlideScopes came to the first ER that I was in, we didn't have the rigid stylets. So we were just using the old soft stylets,
Right.
and struggling to get the D blade angle.
Yep.
And you'd pull it back out and it was all straightened out again. And you're like, what's going on? And then someone finally bought, I guess someone was too cheap. And finally this package of the rigid stylets showed up, and it was like game changer.
Yes, I can fully understand.
Yeah, there keeps being these little medicine shifts. But what's interesting is that, to me, one of the things that's interesting is that you were not doing procedures other than hospitalist medicine procedures. And you had about 9 years before you, from residency into ER work, and felt like that was a decent transition. It wasn't difficult. You can take some classes on things. I think that's one thing that, as we sit on some credentialing committees, we look at docs who might have had gaps. And it's like, well, do they still know how to do this? And surgeons are all like, well, I might not have done a cholecystectomy in like 3 or 4 years, but I could do it in my sleep. And it's the same with a lot of procedures where once you know how to do them, it's very ingrained. You might do a brief refresher and then you're good to go. And medicine's medicine. If you can do hospitalist medicine, which is complicated patients and vented patients, ER is a little bit easier in some ways.
I would be hesitant to say easier, but you do have more focused problems.
Yeah.
And so I agree. Yes, in hospitalist medicine, we tend to look at, we get detailed in lots of different problems, whereas in the ER, sometimes we're focusing on something. So you have to shift your brain a little bit.
Yeah.
Yeah, as far as jumping back into that, a lot of it is, a lot of the same skills translate. In family medicine clinic, you do a lot of suturing, you do a lot of skin biopsies and repairs. You're doing joint injections in clinic. You're doing all kinds of things like that. So
you were saying just the shift in mindset too between ER and hospitalist. How does that work for you? Like, I do both as well, and I find it hard because you're going through all the problems, but then you walk into an ER shift and you're like, oh wow, they have a lot of problems, but what's the one thing that they're here today for? And how do you constantly switch between the two?
I just try to, like you said, focus on that one thing that they're there for. Sometimes it is challenging if somebody does have lots of chronic problems to not delve into them too much and start digging through records, especially if you have a good electronic health record, and then you can start finding old records and you can get lost for an hour and you don't have time to do that in the ER. Yeah. And so focusing on what that person's there for. I often know if I'm turning into too much of a hospitalist at shift change when I'm trying to give my hand off to the oncoming physician if my report's too long, because they'll say, okay, what are we waiting on? Next patient.
Yes.
So, but I think as far as for me, like doing both things, it helps me because I'm often trying to think like, okay, what's this person gonna need to be admitted? What do we need? What does my hospitalist need? The other thing is like having done outpatient care for a decade, I try to think, what does my outpatient doc need also?
Yeah.
Just the same way as whenever we're doing, when we're discharging somebody from the hospital, when we go over it with the students, what's the purpose of a discharge summary? This is your outpatient and provider only has a few minutes when this patient shows up from the hospital. So you've got to give them a good report.
Right.
And so that's what your discharge summary is for, so you can hand off that patient. But I think being able to have that experience in those areas is helpful.
Yeah. You made this sign of like a good report, and it's kind of like a small box.
Right.
Reminds me of like handwriting.
Right.
It's
Yeah.
not the Epic system pulls in copy and paste from.
Yeah, because like if you look at most of our primary care providers, their week schedule is already booked up. And then we're going to tell every patient that leaves they need to be seen within a week. And so they're going to get double booked on their primary care provider schedule.
Oh, that's true.
So their primary care provider is seeing 2 patients in a 15-minute slot. So they have 15 minutes to see 2 patients. So that means that patient gets about 3.5 to 4 minutes with their provider. So you can't send them 15 pages of a discharge summary. You have to send them something that is very reasonable, that tells the story and tells what they need. Otherwise, that patient's going to get lost.
Yeah.
In that follow-up.
I mean, our healthcare system's so broken if that's how many minutes the patients get with their primary care provider. But it's a good point too for the ER, like the medical decision-making ER course, the end of our note should reflect a succinct, this is what happened, this is what they need in follow-up.
Yeah.
That would be really helpful too.
Yeah, I agree.
I've not thought about that. Because we have a few providers that say, hey, we've got slots, don't worry, we'll get them in, just tell the patients, follow up in 2 to 3 days, we've got open slots for them. But there are probably plenty of primary care docs that don't have a packed panel, and so they have everything filled because they need it filled.
Yeah.
And we're double booking them.
Yeah. Yeah, for them to be seen within a week, or for most of them, they're going to be double booked.
Yeah.
Which is really challenging.
It's fascinating. So you talked a little bit about being in family medicine, the type of training that you had, and the experience you had outpatient before you started to do both hospitalist and ER. What advice would you give to family medicine docs who are in the middle of their residency and they're enjoying their ER, but they also enjoy hospitalist medicine? What do they need to do to be well prepared to be able to do both, or to do a combination of like outpatient, hospitalist, and ER, or some kind of subspecialty, sports medicine, or something like that, and pick up some ER shifts? Like, what should they do during residency?
I think it's spending time in the things where you might feel that you need a little bit extra hands-on experience. If it's something that you think that you need to get a little more exposure with ER procedures, then spend some time in the ER.
Yeah.
One thing that we would do during residency was if we were on call in the hospital, we would just go to the ER. And if there were any procedures, we would do them with the attendings that were in the ER. Well, it wasn't wasn't necessarily my ER rotation, but I would just do any lines and chest tubes and thoracentesis and LPs that way.
Yeah.
And it's a great way to be able to get some extra procedures. And they're more than happy to have extra sets of hands helping out.
No, that makes sense.
As far as inpatient work, most of the residency programs are going to have plenty of inpatient experience. I think it just depends on how much of the complex patients that you're getting exposure to. I did interview with one program, not local to this area, but with one program who their inpatient experience was basically, well, we talk to the community doctors and they just tell us what orders to put in. And that was their inpatient experience. Like, well, that probably would be challenging if that was my only inpatient experience.
Yeah, there's not that breadth.
Like you're probably not critically thinking about the patient and managing the patient.
That's probably true though too for the large academic centers, because you can get this long list of consultants and you're just putting everybody's consultants report together and you're managing almost nothing.
Yeah.
And you have to think critically, how would you do this when you're on your own?
Yeah.
And a little bit too, like you practice in rural ERs, so you're the only physician.
Correct.
And I know I talk with some of our residents who are going through an ER residency program and say, what would you do if you're the only doc? You need to be thinking about if you don't have a trauma team to call, if you don't have OB, which makes you happy.
Right.
If you don't have neurology and cardiology, you don't have an MRI machine, how will you manage those patients? Because that's the reality of thousands of the ERs in the United States who need good physicians. And you do need to think critically and be prepared. Makes sense. Some of my procedures I also got by like going down to the OR and getting trained on art lines there, intubations with anesthesiology. If you're in a big enough place, there's IR, and so they'll put lines in all the time, and you get to do that. My favorite thing about IR was that they would leave the wire and walk out of the room and go take the x-ray. And I was like, wait, aren't you supposed to always hold the wire because it could get sucked up inside the patient? And they all were like very confused. Like, we've never heard of anything like that before. Like, you have to push that wire in. So it was fascinating to see their perspective.
Yeah.
So we talked a little bit about sitting on a credentialing committee and deciding who actually becomes privileged to do ER hospitalist work. How did you get involved in medical leadership, and when did that start?
That's a good question. So I guess my first opportunity to be involved on a committee was back in residency. One of the requirements that we had were that we had to be involved in one committee at the hospital. Every resident had to be involved in one committee. The one that I was involved in then was the cancer treatment committee, or the tumor board, so I sat on that one as a resident, and that one for me was mostly just education, and it was very educational to see all of these physicians come and talk about the perspectives of cancer care. When I came to my first real job, I guess, then I started looking at how I could be involved. And I can tell you that if you're willing to be involved, hospitals will let you be involved.
They're desperate.
They're for the most part, they're desperate for people that want to be involved. For me, I enjoy doing it because some of the work that I do, I'm going to learn from the other docs that are on the committees. So if it's peer review and we're discussing cases and we have a surgeon present a case, or we have a cardiologist present a case on why a specific patient would be managed this way or why they should have been managed a different way, I learn from that, and I really enjoy that.
Yeah.
From other things like the medical exec committee, or I work with infection control and pharmacy and therapeutics. From that point, it's really seeing how the hospital works. I'm one of those weird people that I like to see how hospitals solve problems.
Yeah.
And if you look at, I counted up one time from how many hospitals I've worked in. From the time my first hospital was when I was 19. I was a tech as a college student. And I'm up to, I don't know, 25 or so. But hospitals deal with we all have similar problems.
Yes.
That they're trying to manage, but how they try to solve those problems in the same ways. And so looking at those inner workings, I think gives you a better idea of why some of the things out in the day-to-day are happening.
Yes.
Because it can be, healthcare is frustrating. It's frustrating. It's frustrating at times when we're trying to, like we want to see a patient, make a diagnosis, recommend a treatment, have that carried out, and a patient get better. Like that's what we want to do.
Yes.
But, sometimes when we don't have an MRI machine, well, why don't we have one? Well, it's not in the budget. Why is it not in the budget? And various other things. Or why don't we have IV Ativan right now? Oh, it turns out no one has IV Ativan right now. It's really helpful to see that, to me, to understand just the inner workings of the hospital.
Did you feel like you needed some kind of better training or some certificate in order to become a physician leader or sit on those committees and have an opinion, or was
No.
it just you just walk in?
No. I think just being you. I do find something that happens like after you get out of residency, there are some things that people think you do know because you're a physician, and they think you have a lot of expertise in some things that you haven't learned. Around like the insurance world and the billing world and all of those things, which aren't necessarily our expertise sometimes.
Right.
We're expected to know more things than what we actually have been taught. But as far as being involved in committees and helping out with leadership in the hospital, no. Now, if you do want to become more versed in one of the things, peer review, or how to be a good president of your medical staff, etc., there are courses to take, and hospitals will send you to those courses. I went to one of the peer review courses several years ago. It was really good, but as far as getting started, no.
Yeah. I feel like a lot of it is just discussions, and you're learning and you're helping just read a policy and say, yes, this makes sense, or this isn't actually how we practice medicine.
Yeah, it is. It's communication.
Yeah.
Communication is so important in what we do, and the other things that on hospital committees we have, we have any committee has a group of physicians, but then the hospital will have some of their staff with that committee as well. So, which has made it very nice now because as far as the logistics of keeping everything together has made it much smoother, so that the agendas and the policies and everything can come through and be updated with the hospital staff.
Yeah. One of my favorite, I don't tell this story very often, but I was on a quality and safety committee at a hospital, and for a few years, the maintenance would come in and give their presentation. And it was like about locking doors or if the HVAC system was working. I was always like, I understand we need that for the hospital to run, but I don't understand quality and safety with that. And then the director one day brought forward and said, oh, there's this airwave change where they're going to change what signals are blocked by the government and open up. It was like the FTC opening up a section for consumer electronics to use some airwaves. And he checked it against the Bluetooth cardiac monitors and said it's too close, so we needed to order a new system. And it was just a light bulb moment that this guy was passionate about his job and he was doing something really important, reading through FTC communications to see, and then connecting that to the own devices in the hospital, so that we didn't have a day where somebody drove by with something and all of a sudden all our cardiac monitors are out of whack. And it was just really neat to see how many different people are involved in making a big hospital system work. Just being able to be part of that too was neat.
Yeah, I agree.
It's important to be involved in leadership, important to be involved in hospitals. I definitely have noticed over the past decade, physicians not being as involved. A decade ago, it was mandatory to attend all medical staff meetings, and you did quarterly. And then we've been a part of the committees in many hospitals where we've started to scale that back, or at least once a year, and then we no longer mandate it. It's just quorum is whoever's there. Thank you for showing up.
Yeah.
Physicians have been less involved in the healthcare of their hospital, which is unfortunate because then it's run by non-physicians and there's no physician voice.
Yeah.
Do you have any other thoughts about physician leadership or advice for young residents who are interested in physician leadership other than just go do it?
My biggest way of doing it is just to lead by doing. You strive to take care of your patients and take care of them well. And then, as you're doing that, you have these opportunities are going to come up.
Yeah.
And if you show interest, you'll probably have more opportunities than you have time for.
It's very true.
Yeah. But all you have to do is be interested and want to be a part of that, be a part of your hospital community.
You mentioned communication being this really important component.
For sure.
How much communication specific training did you get during med school and residency?
I don't remember that it was a specific course that we had. I can't remember the name of it. We had it in the afternoons, but where we would work on communication with patients and families. We would have groups of interdisciplinary meetings where we would have med students, nursing students, pre-law students, or law students, kind of where we would meet together and discuss cases.
Nice.
Residency, some things that we did. I can remember some distinct things of being coached by some of our attendings when we would have to sit with families and give them bad news, and have that attending there with us. And rather than the attending saying, you know what, I'm just going to take this and do it, and say, you know what, this is your patient. Go ahead, and I want you to do this, but I'm going to be here with you. And so we would sit and we would talk with that family. We would go over things, and then we would meet outside the room, and that attending would go through with us on things. So,
Wow.
yeah. So, given those opportunities, I think were really useful.
I feel like it's interesting to me that there's only a little bit of like the med school application or the interview process. They want to make sure you communicate well, but it's primarily about your scores and getting in. And we find that on peer review, the smartest doctors are not necessarily the ones that have the highest scores on tests or things, which we don't even score tests anymore. But just because they have a lot of head knowledge doesn't mean that they'll be outside of peer review. Like you can have highly intelligent doctors that just don't communicate well with their peers or with staff or with patients, and that leads to a lot of problems. And then you have doctors that communicate extremely well, and you don't even know if they're highly intelligent or not because they communicate so well and so clearly. I just find that fascinating, sometimes the dichotomy in our system between communication being so important, but that's not who we initially try to hire into becoming doctors.
Yeah.
Med school's all about memorizing textbooks. For me, it was after residency that I really had any formal training, and was a lot of self-taught and then a lot of courses online of just how to communicate more effectively, compassionately, how to have empathy. And a lot of it came from being a physician leader and then having to teach other people why you can't say such things to a nurse or to a patient. I wish we had that more in med school and residency.
Yeah. We try to work with, even now with, the med students that come with us, just on taking the time to sit down with their patients and talk with them and spend that time with them.
Yeah, that's important. Just that time. Something that when you're in a busy clinic and you have 15-minute slots, you can't do. Part of the frustration of medicine, or if you're understaffed in an ER and you can't sit down and talk to the patient. I used to tell the scribes how we'd point out sometimes when the family member would bring up something else that the patient didn't, and it was really important that they did. And I'd say patients always need an advocate, because the doctor's in there trying to figure out your main problem and treat it and move on to the next patient. And if you don't have an advocate, you also feel that rush, even if they're directing their questions at one thing in the ER. And ER docs are just not good hospitalist doctors, because we have to move through. You have to treat the emergencies and move on. And having an advocate is really important.
Yeah.
Well, I appreciate it. Thank you so much for having this conversation.
Yeah, absolutely.
Looking forward to future conversations.
Thank you so much.
Yeah.